morning, everyone, ladies and gentlemen. It's a pleasure to be here and to share my experience in brain tumor imaging. Today, my role in the next 25 minutes or so is going to be to introduce the role of a conventional tracer in brain tumor imaging. In brief, this is going to be the outline of today's talk. I'm going to talk about the role of FDG, but main of amino acid traces, their mechanism of action, main clinical indications, protocols of acquisition recognized by the international guidelines, how to report the scans, to how to image, interpret, and quantify our scans. Then I will finish with the main limitations and general consideration in brain tumor imaging. Before I move on, let me say what has been already mentioned before. Gold standard represents, the MRI represents still the gold standard in brain tumor imaging. Nevertheless, there are clearly limitations, in particular in non-contrast tumors. In cases of non-enhancing tumors where the brain, there is no disruption of the blood-brain barrier. There are the international groups, including the RANO and IANO neuro-oncology groups, that have introduced new parameters in MRI for functional and morphological images to better assess the images, in particular in treatment response evaluation. Nevertheless, these parameters are not quantitative. We have the fortune to have a modality which can provide real quantitative information. Before I move on, I want to ask the audience, how many of you use PET tracers to evaluate brain tumors in your center? Please. Okay, I mean, let's say 3, 4, 5% of the audience. Look at this slide. So this is a center in Germany, not on the other side of the world, but very close. And as you see, there has been a rise of the growth in the number of cases in the last 15 years. In some cases, as you see, they scan even 1,000 patients here, mainly for recurrent glioma, but for many other clinical indications. This is going to be my first example. Here we have a patient with a non-enhancing lesion in the region of the left thalamus. Difficult to see on DWI and corresponding ADC maps. On FLAIR, clearly there is a signal change, but incorporating the left thalamus, the basal ganglia, putamen, external capsule, probably the anterior commissure. We scanned this patient with FDG, clearly demonstrating a focus of uptake. But we all know that there is intense tracer activity also in the cortex, which impairs the evaluation of the brain and potential other lesions. Then we scanned this patient with an amino acid tracer. And you see, in addition to the main lesion, there are several other spots, including the extension of uptake and spread of disease to the region of the basal ganglia. This turned up to be an anaplastic astrocytoma. So what are the main indications? Glioma, meningioma, CNS lymphoma, and brain metastasis. However, Today I will mainly focus on glioma, and I will only mention at the end brain metastasis, mainly because they share the same traces, and also the assessment of the same clinical indications. So a couple of words about FDG. I don't want to say that it's useless, but there is a very limited clinical application for this tracer. Of course, in particular at the beginning, FDG has been proposed for many clinical indications. But the reality is that there is a very limited value, in particular for low-grade glioma, mainly given the very high background activity. Authors proposed possible cutoff and threshold values to distinguish high-grade and low-grade glioma based on survival. With interesting results. Other authors, and this is something that can be done if you don't have any other available tracer, proposed to use the delayed acquisitions, mainly because on one side there is increased activity within the tumor, and then with delayed acquisition there is reduced background activity. I mixed up the display, but anyway, the main clinical role is, however, with amino acid traces, mainly because first there is very little background activity, and there is a selective uptake in the tumor, mainly mediated by two transporters named LAT1 and LAT2. Once inside the glial cells, then the DOPA, F-DOPA, and methionine undergo further metabolism, while fluoroethyltyrosine does not. So three main traces have been proposed for brain tumor imaging. Methionine, which is a fantastic tracer. The only problem is that it's a carbon-11, so requires to have a cyclotron facility. And given because of the, of course, of the half-life, there is some problem related with quite high background activity, but it's definitely a very useful tracer. The most studied tracer in literature is fluoroethyltyrosine, which has a very high tumor uptake with very low background activity. And most recently, DOPA, F-DOPA, has been also used quite extensively for brain tumor imaging. At the beginning with mixed results, mainly because it was thought that the uptake in the striatum could impair the assessment of tumors. But then also the striatum can be used for another reference point for the evaluation of and comparison with the tumor uptake. So I always receive the question, what is the best tracer? What is best to use among the different amino acids? I reported that it's plenty of literature of what is the most useful in practice. I reported two papers, in particular around the 2010-15. Many papers reported the comparison, head-to-head comparison of different traces. Here, the study showed in the recurrent glioblastoma and newly diagnosed glioblastoma much higher activity in tumor for FET compared to DOPA, which whereas DOPA clearly showed increased background. But on this other paper, there is the completely opposite outcome. As you see, this is the DOPA and this is FET. For high-grade and low-grade glioma, the SUV max was always better for DOPA compared to FET. Again, the personal experience and the reality is that if they can have a similar clinical value. So if you have one, go for it. Only taking bear in mind that can be some slightly technical differences, including there is a slightly earlier better activity in DOPA, and the static acquisition should be done after 10 to 30 minutes compared to FET. Carbidopa has been suggested by many, but I don't think that is useful because if from one side increase the uptake within the tumor, but then increase also the background activity, so there is no real point to administer carbidopa for brain tumor imaging with F-DOPA. There is physiological uptake in the striatum, which can be used also for reference to tumor background. Let me just mention in this slide and with a couple of words other traces. We have had some experience with Colin, is a tracer of proliferation, probably as a very, probably is the best tracer with a very low background activity as shown here, but unfortunately on the other side also the uptake in tumor is very low compared to other amino acid traces. A different argument should be instead said for fluciclovin. I think it's a great tracer. It's another amino acid PET radiotracer with a high tumor to background ratio. See here the comparison with methionine. I took this slide by Professor Lowe in the last ENM. This is a tracer originally approved for prostate cancer that has shown definitely a clinical value in brain tumor imaging. There is a very low uptake in the healthy brain compared, for example, with FET. However, this analysis showed slightly lower sensitivity compared to the other traces. Again, my personal experience, I don't have a real personal experience outside prostate, but definitely the background that I saw is very low. My idea reviewing the literature is that can be alternatively used for brain imaging as well as the other amino acid traces. So again, if you have it, go for it. Don't expect miracles, but it's definitely a very great tracer. Coming to the protocol of acquisition, slightly more radioactivity should be used for methionine as a carbon 11 tracer. The guidelines suggest fasting for 4 hours to avoid the alteration in protein and amino acid metabolism. Then the 20-minute post-acquisition is suggested for static imaging, and all different papers in the literature suggest to perform dynamic imaging, usually 40-50 minutes post-injection with shorter frames at the beginning and progressively increase in duration. How to report the scans? Of course, visually you can dichotomizing in positive or negative, with negative no increased uptake in the tumor, or you can provide a semi-quantitative evaluation. SUV max can be, of course, reported, but is not mandatory. Whereas the TBR mean and TBR max are recommended and seem to correlate with aggressiveness of tumors. You calculate the ratio between the SUV max or mean in the tumor divided by the background activity, which should be taken in the contralateral hemisphere, taking in account the white and gray matter. The common literature says that a threshold of TBR of 1.6 correlate with aggressiveness, and for DOPA, the tumor to striatum more than 1 is another parameter to consider for the tumor grading and evaluation of recurrent disease. Also, different thresholds have been proposed for including the time to peak for the dynamic analysis, or the SUV max, the increase or decrease of SUV max per hour. The simple visual evaluation, I think that is already enough, just looking at the behavior of the curve. In this case, to do a simple analysis, you can plot the SUV max of the tumor on the same plane during the different frames and build this type of curve. If you see the behavior of the curve is like a plateau or a continuous wash-in with no washout, this is definitely indicative of a low-grade tumor. Whereas if there is a peak of the curve and a rapid washout, this is most likely consistent with high-grade tumor or recurrent disease. So what is the most common clinical indication for amino acid at primary diagnosis in tumor recurrence, for differentiating glioma from treatment-induced changes, in therapy monitoring, and eventually in evaluating malignant transformation of low-grade to high-grade gliomas. This is a common example. The clinical questions that we usually ask to answer by clinician are, one, if this is a malignant lesion. Then what is the best site to biopsy, and then help try to give an impression of how to approach and treat this patient. So visually, this is a non-enhancing lesion on MRI. Of course, again, a difficult assessment, also given the quite diffuse change on flare. Visually, this is a positive scan. Clearly, you can target or help the surgeon to target a biopsy site. Reporting-wise, you give the semi-quantitative values. As you remember, I gave you the 1.6 cutoff for distinguish benign from malignant lesions, or benign, let's say, a low aggressive lesion. The slope of the type of the curve is more consistent with aggressive tumor. This tended to be an IDH negative, of course, glioblastoma. So Professor Chalmers introduced the importance of the new classification. That is completely replace the previous WHO proposed in 2021. It's very many papers came out from trying to compare and correlate the aggressiveness of a tumor based on the molecular classification and quantitative parameters. As you see, the more intense is the activity, the more aggressive is the tumor. And this is one of the largest studies performed in the molecular classification. This paper suggested that there is a clear correlation of dynamic and static parameters and the molecular status, including IDH negative and co-deletion of 1p19k DNA chromosomes for oligodendrogliomas. Also, and I think a similar scatter plot or Kaplan-Meier curve has been already shown in the previous presentation. It's important that in particular dynamic PET can correlate with aggressiveness in terms of molecular status. Here the authors plotted the rise of the curve, the TTP, so time to peak, less than 12.5 minutes, and with the survival of patients with a different type of tumor, and they showed that a clear independent marker of survival based on the dynamic curve. In practice, the shorter was the time to peak, the more aggressive was the tumor. It's important to understand before treatment how to possible treat this patient, so to have a clear plan. Here is an ambiguous case because, as you see, the tumor to background and the tumor to striatum are quite high. However, the type of curve is more in keeping with a benign lesion. It's definitely quite aggressive in terms of infiltration of the brain. So the approach and the bulking in this patient is essential because you can eventually debulk this patient maybe a couple of times and not do everything in one and possibly do a subsequent radiotherapy approach. So knowing in advance that the grade and possible aggressiveness of this tumor is essential. This turned out to be an IDH positive grade 2 astrocytoma. So this is a sort of personal experience that I think is extremely important, not only for surgeons, but for clinical oncologists. So, Professor Chalmers, where would you treat this patient based on the MRI images or based on PET? So look, if we contoured in green the lesion shown on the MRI here, and in red the uptake seen in PET. As you see, red and green are completely different. So if you have to treat maybe with a proton beam therapy or with some sort of stereotactic therapy with a more focused radiation beam, it's definitely very difficult. And there is we found that the overlap in low-grade and high-grade glioma was significantly different. For low-grade glioma was up to 80%, so it's quite the same, but was very low overlap for high-grade glioma. On the same experience, we also integrated the PET values with the MRI assessment for the differentiation of low and high grade glioma, and we found that the best correlation and outcome was when we integrated the static parameters and the perfusion values as shown here. Again, in a different possible clinical application, transformation and guiding biopsy. So not everything that glitters is gold. There are pitfalls, as in all PET studies, and we are well aware with FDG. Similarly, in neuroinflammation, there can be potential false positive, as well as false negative. The reason why is probably related to lack of transporters of amino acid. This was a case that on imaging, on MRI, was initially diagnosed as low-grade glioma, biopsied, turned out to be a wild-type glioblastoma. But PET is completely normal. An important role is definitely in recurrent disease. This is indeed an unmet clinical need, largely evaluated by the neuro-oncology groups. MRI can be equivocal in 15% of first follow-up. So I show you this example, simple one clinical practice, patient before treatment, imaging 8 weeks after chemotherapy. What would you do? You have to wait another 6-8 weeks with the clinical question, if this patient is, yes, you can, or you can do a PET. 4 weeks later, there is a regression of this area of abnormal enhancement, but with PET, this was already clear at the beginning. And this is probably one of the largest studies confirming what I just said. Of course, this is the survival in a patient with treatment-related changes, and this is with a clear progression based on histology on follow-up. And you see that the same patients evaluated with PET clearly showed that they are quite similar behavior of the Kaplan-Meier curves, reflecting what I just said, the important role of the last 3 slides. I can also skip just going to brain metastasis. Brain metastasis share the same amino acid traces and the same clinical reason because radionecrosis is an important point, especially in this patient. So again, the normal clinical question, whether this is recurrent disease or radionecrosis. To be honest, I would say that based on imaging, that this is radionecrosis, but that doesn't really matter. Here PET, clear uptake, recurrent disease. No, they look at the behavior of the curve. Here, no uptake. Also, the curve is going up. Here, visually positive. Uptake, parameters, all in favor of progression. Here, mild uptake, quite well, 1.6 is the threshold, so it's 1.7. The dynamic curve is going up. This is a radionecrosis. So, 2 main limitations. One is availability of traces. In the UK, we are far behind the rest of Europe, US, in the availability of amino acid traces and other radio tracers. We have all to work on the same direction, pushing the radiopharmaceuticals, the company on towards the availability of this tracer. And the other main problem is reimbursement. Just conclude saying that I strongly believe that this is not a fancy research tool, but it can be used in clinical practice, is used in clinical practice everywhere in Europe and in the world, as shown in the picture that I presented at the beginning, can replace or can be complementary in many cases to MRI, providing additional information. Thank you very much, and let me also thank the support of the ENM Neuroimaging Committee, which provided help with some of the slides. Thank you very much.